Hello, everyone. Welcome. My name's Naja. I work at the CDPC, and it's on the whole stimulus conference. So this is so exciting. We're doing our first exclusively French webinar. So if you're not understanding what I'm saying right now and you need English interpretation, please look at the bottom of your screen. And we look on the bottom of the Zoom bar, and there's an interpretation icon or button. And we have two interpreters from Co-op Go who will take care of doing simultaneous interpretation towards English for this event. First of all, I would like to thank Julie Saleh and Alexandra from Caput for helping guide me in the organization for this whole event. It's our first French webinar that's exclusively in French, and we have a particular accent or focus on Quebec. So today we're going to go do an overview of different perspectives in harm reduction in Quebec and the whole world surrounding that. And I really want to thank everyone who's reaching us from the international stage. We have even organization from Lebanon and from Mexico that are here with us today. So that's so exciting. And I really also want to invite you next week. We'll have another webinar that is on a toolkit on bathrooms that are safer for drug users and harm reduction. So safer use bathrooms. And it's the December 8th, Thursday. You can go on our website to sign up right away. And beyond that, at Stimulus, we have been counting for the past year. We're working on a larger conference that's going to be October 2023, I think October 5th to 7th in Ottawa. It will be our first conference since 2018, and we've been working really hard on it with this whole team to create this event and to make it one of the biggest get-togethers in all of Canada in terms of harm reduction and drug politics and policies. So if you want to learn more about how to support us at for organizing this huge conference and funding this huge conference, if you want to support us in other ways as well, you can please go to our website and send us an email. If not, I will also share my email and my colleagues in the chat a little bit later. So without any other ado, we're going to pass it over to Frankie B, who's going to be facilitating the panel today. And I also wanted to say, if you have any questions during the webinar, don't write them in the chat, please, but please write them. We have a Q&A bot, like question thing that's also in the bottom in the menu bar from Zoom. So if you can send that rather than in the chat, really the questions in the Q&A box. So thank you. Have a good webinar. Hi, thank you everyone. I just wanted to start by saying I'm sorry. I have a little bit of a cold, so I might be hard to understand, but I'm really going to try to express myself clearly and as slowly as possible to help the interpreters. So my name's Frankie B. I use he and they pronouns, and I'm an adopted transnational Haitian. At the moment, I'm working as a supporting coordinator for education and knowledge about chemsex issues at the ACCM, which is the AIDS Community Care Montreal. It's the only Anglophone organization in Quebec that helps people with HIV. And today, before getting started, we're going to do a land acknowledgement. So, in general, I'll explain what is a land acknowledgement. A land acknowledgement is a way to formally declare that we recognize and acknowledge unique relationships and the persistent relationships between Indigenous people and their ancestral territories. To recognize the land is really to express our gratitude and appreciations and honor the Indigenous peoples who have lived and continue to live and work since the time of memorial on these lands. It's so important to understand the history to how we live and how they live on this land, and to this land acknowledgement do, is doesn't it's something that exists in the past only. It's the colonial project is still happening, and we have to continue to raise our consciousness of how we participate in the continual colonialism that's still happening. So, Stimulus Connect is happening at the moment on the traditional territories of Kanyen'kehá:ka, what we called Montreal. It's also known as Geojage in the Kanyen'kehá:ka language. And it's always been a meeting place for different Indigenous peoples, as also the Algonquin people. And since our mandate is focusing on social and environmental justice, we think it's so crucial and important to acknowledge colonial past consequences and its current consequences. So we encourage everyone to take time to learn more about the history of the land, the territory, and to support Indigenous resistance here and on all of Turtle Island. So now I'm going to pass it over to Anais, who's going to speak to us a little bit about harm reduction for different sex workers. And especially, we're talking about trans sex workers. So it's over to you, Anais. Thank you so much, Frankie. So my name is Anais. I'm from Montenegro. Hello, everyone. My pronouns that I use are she and her and elle in French. And we're here with the Stimulus Cooperation Group to do this conference today. And I really want to thank Anaya today for organizing this event this afternoon. And I'm here to speak with you all about we're going to speak about the history of Cactus. That's the organization that Aztec works with, and it's for and by trans people in that branch of Cactus. So it's called Aztec. And so I'm going to give you a little bit of the history of what Cactus mission is, and how, and then what is Aztec's mission and how they're linked together. So, Cactus is there to prevent HIV transmission and other sexually transmitted diseases of between drug users, specifically injection-based drug users. The organization uses a harm reduction model in all its work. This is part in understanding that prevention of HIV AIDS has to be situated in a social context that promotes health and people's autonomy. Our main program is prevention, as I just said, for people who use injection drugs. And we also distribute harm reduction effects like syringes, condoms, create safer drug injection spaces. During the pandemic, it was really hard. And this year, we've been able to go back to these activities to look at where safer injection sites on the island of Montreal. And we are here to promote health of our target population. So, to share a bit who I am, I'm a worker on the ground in Aztec since 2019. I do intervention work, and I wanted to talk to you a little bit about the foundation of Aztec, which is officially when we started in 1998. However, everything that we've been working on since the creation of Aztec, we've been working with, it was before us in 99, it was on St. Dominic Street. That's when um, Cactus started during the HIV pandemic. And we were working with different trans people who are also affected by the HIV pandemic, and it was being hit really hard by this pandemic. I'm sorry, it was in 92. So actually, no, it started in 89. Sorry, interpreter made a mistake. It started in 1989. In 92, they were able to hire workers since 92 to the official foundation of the organization, which was 1998. It's Viviane Namaste who took the role and was the official speaker for our organization. And um, I was starting my transition in these years, and I wound up being one of the first, or what was one of the members of Aztec, but I was one of the first who was a sex worker amongst the Aztec workers in that time. So it was during that time, just up to now, with the creation of Aztec was really, and geographically, we were focusing just on Montreal. And going back to like the 2000s, even 2010, we've been moving a bit wider out and being able to give services to the population all over the province, actually, because there's a lack of services. So as tech has been in high demand from different publics, and how can you actually help trans people who are using drugs outside of Montreal, because there's a loss of resources. We've been trying to work on that, and our goals have been really trying to offer services to people at a wider range all across Quebec. However, it's just been recently that with my work and the work of the whole team, and over the years, we've been able to add more people to this team, right? We're about 5 people plus a coordinator at the organization. So I'm the person who works, I've specific intervention is to do different partnerships with health specialists, um, this like the civil, more political things, and also work at the clinic levels for the safer use, and then other community organizations that we see here. So for the target population. So that's I've been really that networking role. One of the most important goals that Aztec has to try to fill out is really the access to health and the health system. For when we're talking about really focusing on harm reduction and the access to appropriate resources. So when I was talking about the historical, so like say Aztec officially opened the doors in 89, and then the people that were getting involved in Aztec, it was developing the project at the beginning of the 90s. And then Viviana was starting to go to different bars and the streets of that time, because we really were focused all on Ontario Street. There was sex work happening there. They basically from downtown to all the way to Hochelaga, but before the most trans people wound up were around Atatican Road to like Delormier about. So then you can see that area in Montreal. And it was really Viviane who was working specifically in that area. And then moving on from 89, we started meeting weekly, like once a week. We started seeing common issues that were touching all of us and that we needed to develop more services for our community. And thinking about that and to be able to figure that out in the 90s, in 1999. And so then we opened up further in the 2000s, and sorry, and we saw Aztec was be able to take a bigger space and take up more room and be more present. And I was hired into the 2000s to do street work and to really be able to go to bars, talk to the girls and the women there, and to speak about their day-to-day lives of what was happening around, what were their issues. And because it's for and by, because I also was living through those same issues, and also because if you didn't have Canadian citizenship, you're not allowed to change your pronouns, your names, and such. So that was a huge struggle that that the coordinators, different workers that we brought on the team over the years were able to try to help people to get their permanent residency, and then with the permanent, and then struggle for people who only had permanent residencies, and also then asylum seekers that could then eventually also benefit from an act um that they started in 2013, but it was only for to change your pronouns. So before they were only allowing Canadian citizens to change their pronouns, and then there's different criteria to be able to do vaginal and different um medical and sex change procedures. And we were working on getting those procedures for our members. And at that time, we were working with other organization who work with trans or people. Um, we were able to work on changing policies to be able to people could change their names and pronouns just with permanent residents, and then also people who were officially refugees or asylum seekers and political asylum seekers, that they could also do their change. So in 2019, Aztec was able to even go further and be able to work with immigrant and migrant trans people, and because we see there's this population and this community is growing and becoming mixing more cultures, and more people come and use our services. So I'm really close with migrant people and their this are members, to follow them throughout the whole process to actually get set up in Quebec. And we can see all the different issues that can arise with this hard transition, and we do our make sure, and we work to like try to figure out how they can get set up in the province and to make it actually real, something realistic and something they can do. And then we also work at Aztec with different clinics, and these clinics work on different hormone therapy for people. So then we are having different ways for people to access resources, and we're adding to that list over the years. And with the pandemic, we've had chance to incorporate and work with other people, and we have 3 official clinics that we have strong links with for different transition therapy, to be able to help the populations that we work with. So today, my colleagues and myself, we share the different roles. Um, I'm doing a lot of accompaniment, and I'm there all the time for people who need support from us, who want to be accompaniment. And we also have the role for if you want to change your official ID and papers, so your pronoun and your change your names, and all the question in supporting migrants, if it's to be able to help them go to court if they have to go through official court processes and for migrant people, but not just migrants, right? It's right, not all the whole country, no, but maybe all the province more that way. And to go back a little bit on the question, um, how before Aztec from its beginning really came out of that there was a lack of services for us and we were dying. And there were no organizations that could come support us or help us. So the cactus was there at the very beginning, and then it was slowly that we were able to work on that since the early 90s, like 92, and we worked that pathway. And so it's really, I got involved as soon as Aztec started. In the late 80s, and I was working as a sex worker on the street mostly, and then I was really in contact a lot with Vivian, and I wanted to I got decided to get involved in a class. I went back to at a CEGEP for a psychosocial class or like a mental health. I went all the way in Saint-Jean-sur-Richelieu in Brossard was I took this class, and luckily because I care so much about my community, and I was able to be, since I was part of this target population, and and I had issues with the cops, and so sometimes I couldn't go, and then I couldn't get my citizenship because of those legal issues. So I started to become more of an activist and work with 20 in two sorry 97. Oh, no, I think 2007, and we did different demonstrations and marches to be able to let people know of our needs for um and it was in August. And now, actually, this year we want to redo some of those demonstrations because we were supposed to do something in November, but actually it wound up not working. So, um, but we would like to, because of the pandemic, it's obviously hurt our mobilizing things because we can't get together as many people. And and I've been trying to work um and I was wanted to get more integrated and work more, and I was able to get hired at Aztec, and is the best a place I could be is to support and help my people, right? So, and we do lots of continual workshops to be able to continue improve and like learn more about harm reduction, especially in certain targeted sectors. And because we're taking up more and more room in society and we're trying to be out more. So for all different drug users, especially we're talking about injection drug users. So Cactus has the supervised injection site on in downtown that's been with it's just been a few years, and Spectre has also opened their doors to be able to be people to be more accompanied and supported. And those are the newer things. and that we've been able to do since in the past, like since 2010, to push forward and do more work in harm reduction. And we continue to do syringes and needle distribution and other safer drug use support to community members. I think maybe, I don't know if that's it, to give a little overview of of our services and our resources, and talking about the in the history of trans people in Quebec, and especially in Montreal, to give a little idea of like how we started in the late 80s and then the 90s, and to do the work accompanying people, because there was still no hormonal therapy that was accessible. And then we worked a lot in urgent situations, coming to support and help other people from our communities. Thank you so much. Thank you, Anais. Thank you for your testimonial that you just did, and all the work that you do for the trans community. It's so appreciated. As a trans person, I really appreciate the work that you do. So thank you so much. And now we're going to move towards Isabelle. It's over to you.
Hello, everyone. My name is Isabelle Fortier. I wear a number of different hats. I'm a member of the board of directors at Dopamine since 2020. I'm also a trainer and community organizer for the Profane 2.0 project, and that helps to train communities or individuals who work in the community sector and to help with administration. I also am an activist for Mom Stop the Harm. It supports families who have members who have suffered from addiction. I started it with memory of my daughter in 2019. She was 24 and had issues with substance use, and she died of an overdose alone in her room in Ottawa. After she died, I decided that I would live my grief through action, and I've been pursuing that action. The action has not diminished, quite the opposite. I would say that I'm doing more than ever. And with Moms Stop the Harm, I was on the board for 2 years and now shifted over to the Stronger Together Canada project. It's a federally subsidized program that creates groups animated by peers for families, grieving families, for those families or individuals who are close to someone who is suffering from addiction. We have started to put together a number of activities over the past few years. I would say I'm the only person in Quebec who's active, especially as really the only francophone organizer for the organization. It's very difficult. It's one of the things I wanted to talk about today, the language barrier for an organization like ours. We're trying to bring together families who are different levels of ease in both French and English that can be challenging. A lot of the work that I do right now, I do alone. However, I do have a mother who recently accepted to undertake the training to become a group facilitator to support grieving families. And now she works with a group once a month online, and she also co-facilitates the meetups. Once a month, an organization holds a drop-in discussion around grief, and so we try to bring people together, try to reach out to people as much as we can. The language barrier for us in Quebec definitely has an impact on that level, especially trying to reach out to parents. But I think there's also different aspects of the stigma that exists around grief. I think that's maybe stronger here in Quebec. I don't know if it's stronger or just different, but we see a lot of parents in the West who are very active, who are really pushing things politically. Maybe it's because the crisis is being experienced differently in the Western provinces than it is here. Here in Quebec, we have the perception, and this is something else that I wanted to raise today. The political decision makers seem to have the impression that the crisis isn't really present here in Quebec. Obviously, those of us who work on the ground know that we're experiencing this crisis every single day. The political decision makers seem to believe that the opioid crisis is only an issue for Western Canada. Our situation in Quebec, both due to habits of use or patterns of use that I think are different and tend to be more common when people use stimulants as compared to British Columbia. And so that can change the perceptions of the political decision makers towards this crisis. The members of Moms Stop the Harm, we don't call this an overdose crisis anymore. We call it a drug toxicity crisis, because our children, those who are close to us, they're not dying because they've used too much. It's because they're using illegal drugs that have been contaminated. And those who are close to us don't know what they're taking. That's what happened to my daughter. She was died from a contamination of fentanyl and centranil, which is the medication that she was taking. When they combined, that's what killed her. So the situation in Quebec has resulted in political decision makers who don't see a crisis, and this is reflected in the funding that's available, the approach that they take to different ways of managing or handling the problems. Another aspect at the governmental level, there's the whole issue around responsibility for healthcare and fund transfers to the province. For example, there was an announcement last week of $270 million announced by the Minister of Health and Minister of Mental Health and Addiction at the federal level. They announced a $206 million transfer to Quebec, but we don't know how these funds will actually be used in Quebec. The funds are simply transferred to the government, to the health ministry for the purpose of improving services at home and mental health services and addiction services. But the way that that's going to pragmatically be used, we don't know. My fear is that we're not going to see these funds being used or sent to the right places where we actually need them. The provincial government, with its national overdose prevention strategy, gave us a little glimpse of the situation. There's broad guidelines that are included. We don't know how those are going to be translated into action concretely on the ground. Within the national strategy, there's no discussion of decriminalization, which for us as an organization is, I think, one of the most important elements that we put forward, and really something that we push very hard for and advocate for is decriminalization and eventually legalization of drugs. We advocate for a safe access to drugs, whether prescribed or not. We advocate for public education to overcome stigmas and to facilitate access to Naloxone, as well as facilitating access to all possible forms of treatment for those who experience challenges with their drug use. Every possibility must be available to individuals who request it and who would wish to pursue any type of process to address the drug use. Elsewhere in Canada, the situation, of course, is different. If we look at the situation of my sisters in Alberta who are facing a conservative government who is closing supervised injection sites, their struggle is, I think, certainly different than the one that we have here in Quebec. We can celebrate or at least comfort ourselves from the fact that here in Quebec, we have good actors involved in harm reduction. We have a number of organizations in Quebec who are doing fantastic work. We are seen elsewhere in Canada and other places in the world as an example to follow in harm reduction, and we can't lose that reality. However, our organizations are underfunded, and that's a problem across Canada. And here in Quebec, I certainly think that that's a very serious issue. There's also the issue that for governmental decision makers, they don't really understand the issues that we're experiencing on the ground. There's a number of grants that are non-recurring. We create projects, they're subsidized, and then once they're up and running, then that funding isn't reallocated and projects have to be abandoned just because we don't have the funds to run them anymore. Just to give you an example, yesterday I was on a committee on homelessness in Verdun, and it's the same discourse that I heard an organization saying we want to put a warming tent together for the winter, and we don't have any space. The city and the province aren't funding programs. They had the authorization to run a RV for the winter, but they only have funding for about 6 months of programming. So it's very, very problematic. The way in which funding is distributed is really hurting programs and organizations. I also want to speak to community action, which I think is really present here in Quebec. It's, I think, a part of our character. There was an article last week in the newspapers saying that there's over 70,000 workers in the community sector in Quebec, and 70,000 people who work every day to make a difference, to try and make a difference in the lives of individuals who are experiencing precarity, who have been marginalized, or who are being stigmatized. That's a lot of people, 70,000 people who are working. It's a significant part of the province's population. The government must recognize the work of these individuals and inject the necessary funds to support these individuals. The statistics show a lot of women working in the community sector and they're not adequately paid. People don't have access to pension funds. They can't really think about any real form of financial stability. It's also the fact that it's often positions that are very demanding emotionally, the energy that we are contributing to vulnerable populations. It's very demanding for those individuals. And that's why we have a sort of a revolving door in the community sector. People get tired, they get sick, they get exhausted, they get tired of living paycheck to paycheck. And we talk to a lot of people who are really invested, but at the end of their rope, and we don't have any recognition from the government that really recognizes the work that these people are doing, which I think is vital. So just to sum up for myself, my grief for my daughter has really transformed my life, even my perception or views on addiction or legalization or harm reduction. I had a total 180 in the way that I see things prior to my daughter's death and afterward, having worked in this field, having studied, having gone to get the information and informing myself. I'm now able to try and reach people who don't understand as well. One of my functions is to give talks or to at least speak out in different environments. We did do some work recently with the ENSPQ, try and create videos to train all of the employees in the healthcare sector regarding stigmatization around drug use. And that's one aspect of my work, try and contribute to projects to overcome stigmatization. I was asked to speak at the CIUS on the West Island. There's a school in Trois-Rivières who's invited me to come at the end of the school year to talk to the graduating students for secondary 5, and the local police service in Verdun asked me to come and present to them after the holidays. And these are opportunities to share what I've experienced, but also to touch on, a more sensitive side of the individuals that I speak to. I think that the voice of grieving parents is very powerful. We need to know how to use it properly to advance our messages and change people's perceptions. For myself, it's kind of become my life mission. It's what animates me and what it's allowed me to better live my grief after the death of Sarah Jeanne. I can understand a little bit better. And I feel like what I'm doing as a way to do justice by her and to honor her just every day. She's always on my right shoulder, helping me in pursuing this struggle. And the struggle is far from over, but I'm very happy to be participating in it, even if it is such a tragic event that brought me to it. I still feel privileged to be where I am right now because I have this support system and network around me that allows me to do the work that I do. And it allows me to appreciate what I have and to share it with others. I think that's pretty much my 15 minutes there, Frankie. Is what you asked us to cover. You had 40 seconds left. Just right on the money. Thank you so much, Isabelle. It was fascinating, really moving. We'll listen to you now, Simon. Yes, hello everyone. Thank you very much, Isabelle. It's really an honor to fight alongside you. And thank you for having set the table and bringing nuance. This is crucial nuance to the context of the crisis, an overdose crisis versus a drug toxicity crisis, and these really important points. Your testimonial as a parent is really moving for me and encourages me to go and see my father. And similar after my mother's death, he had his own 180 as well, from a defender of total prohibition to become a defender of the positions that I find myself in a very similar position as you today. So I'll ask him if maybe he wouldn't want to speak from time to time as a parent, as a francophone as well. And thank you also to Frankie for having set the table. And I want to also recognize thank you for the territorial recognition. I also want to thank Stimulus and the CDCP for offering me the opportunity to speak here today. I'll continue along what Isabelle has begun talking to us about. Right now, we know that the possession and use of drugs and illegal substances, the behaviors that are often associated with it, are affected or dealt with through the criminal system rather than a public health system, even though more and more health professionals are participating or getting involved in organizations that defend the right of drug users and former drug users. We know that this taint is still present. When we spoke with Dr. Goyer recently, and in preparation, he was asking us to look at our arguments for ways to reassure prescribers. Those who write prescriptions are uncertain, and I think the first steps towards a legalization or of harm reduction through safer supply goes through pharmacies and pharmacology. Um, I have long been a defender of the medical model. I still think that a medical model has something positive to offer, especially knowing that the laws aren't going to change from one day to the next. But I remember having tossed out a suggestion to some friends. Well, I don't really present myself. My name is Simon. I work at the SABSA clinic. I also offer some time to Interzone, which is a supervised consumption site in Quebec. It's been open for almost 2 years. So I have my activist side, rights defender, but I also work very closely with individuals who are asked to prescribe for safe supply. But anyways, I don't know what's going on in Montreal, but right now in Quebec, most of the safe supply is for opioids. I am a staunch activist to expand access to that. One of the serious limits that I see right now in the promulgation of safer supply is the lack of directing lines, directives from the doctors, groups, and prescribers. And I think the fact that every prescriber is independent from each other professionally in the way that it's organized, that's not necessarily a bad thing, but it means that individuals can be treated extremely differently if they have one prescriber rather than another, and the power that gives to the individual who is writing prescriptions. I know that I have a case right now where I'm trying to help an individual and support his rights. He feels that they have been infringed upon. I looked through his file. I saw there's a number of elements where I agree with him. His rights have been infringed, but there's a whole other issue of behaviors that sometimes drug users can have in terms of their anxiety. They live anxiety for a number of years. It can mean that they kind of lose it a little bit in their doctor's office, and sometimes they'll speak faster than they're thinking. And sometimes I ask myself, am I defending the unacceptable? But then I have to remind myself that this individual is suffering from this, serious challenge. And when I'm defending people's rights, I try to also put forward the responsibilities that they have. Yes, we have the right to use. We should try and use drugs in the best way possible to reduce harm as much as possible, but it's not all white or all black. Sometimes I surprise myself in saying that we have the right to shoot up, but we have the responsibility to sterilize with alcohol beforehand. But, if you're using behind a shipping container, you bypass the use of the alcohol swab because you're feeling stressed and pressure. There's always a counter example that occurs to me that complicates these ideas. But as soon as we look at things from a public health angle, things become a lot clearer. And so I always try to advance in that direction. From the fact also that here at SABSA, I have a colleague who prescribes in a TAO, and she often tells me that the fear that's there in writing prescriptions. And she was always telling me that she was afraid. And at first I didn't understand, but finally started to understand the responsibility that she has as a prescriber. It's her name. She's the one who signs. It's her professional responsibility. And I started to be a little bit more conciliatory with her and other prescribers. I don't also want to abandon the struggle and just give up. There's a lot of arguments to be put forward, but at the same time, I've become more sensitive to their concerns. But I did ask them something. Let's suppose that we don't go through a medical model and the access to controlled substances didn't go through this medical model. I hope that there will still be individuals there to, if we would decide to federate or create a cooperative purchasing club for drugs, I hope that those professionals would be with us if we had to find ourselves in front of the court, for example, because the laws haven't changed at all. I remain convinced that we have the right to substances. I always think of the conceptual model. I remember at the beginning when I was using this model, it wasn't very it touched on, wasn't often touched on, but I see it more and more often. But the graphic that shows the relationship between public policy on drugs and the harms for users and society. And it is this U curve where at each side we would have total prohibition. On the other side, we would have a legalization without any controls, no regulations. Everything would be accessible without any controls. And that's to say, without any laws to control access. And in the middle, we would have legalization with some type of control, as we can see right now with cannabis, where the harms would really be at their minimum. And so for those of you who are interested in seeing that graphic who don't know it, I'm sure we could find a way to share it with you. It's also available in INSPQ documents and in another document on Compassion Club, which is available in Western Canada. I remember that when we were preparing for this webinar, I had a lot to say. I took lots of little notes all over the place. But I also don't want to start repeating myself. I would say that, well, for now, I would pass the floor. And if anything comes back to me, I'll ask the organizers whether I could maybe speak again. But for now, I would end there. Thank you very much. Thank you, Simone. This is super interesting. I really appreciate it. Etienne, the floor is yours whenever you're ready. Yes, hello. My name is Etienne. I am a member of ADDIC, Association to Defend the Rights and Inclusion of Individuals Who Use Drugs in Quebec. I've been a member since 2010, 12 years now. I want to talk a little bit more about the use of stimulants that we see here in Quebec. It's really a lot, very common. And for the past few years, there has been a significant increase in contamination of substances in general. And this has led to challenges around especially mental health. Stimulants can cause toxic psychosis. It can exacerbate certain mental health issues that are already present in individuals. It can also have another effect where if someone, for example, is being supported for the mental health and receiving medication, the more substances there are in the drugs that they use, the more risks there are of interactions, which can lead to deaths in certain instances. And the case of toxic psychoses, which is something that's happening more and more often, I have a number of examples in my own network of individuals who use and then immediately find themselves in a psychosis. Those individuals have behaviors that could lead to them losing their job, losing their housing. If, for example, someone is persuaded that their neighbor wants to do them harm, or, sets a fire by accident, and the things that can happen. And what happens in these cases, there's very few resources for when these situations arise. Often it's the police who are called. Then if the police are called, it's a serious risk of criminalization. And the police come in and they see that the person has used, that there's drugs around. They could be charged with possession. Or if someone who thinks that their neighbor is trying to do them harm could attack their neighbor and then end up in court, could find themselves having to, maybe lose their housing. And we're currently experiencing a housing crisis where affordable housing is extremely difficult to find, and even less affordable housing is difficult to find now.
The vacancy rate in Montreal is very low at the moment. It's like record low. And so people really don't know what they're using, right? There's been tests that have done recently. We got basically an announcement. We got some information that there's fentanyl in crack, for example, or tests that were done to different drugs where we let's say in speed or something like that, there's like and there's like about 15 different substances in speed, which is like bath salts wind up in speed, and even a hallucinogenic drug. So the bath salts and then the speed and other things, and so those things put together, the person just explodes. They don't even know what's happening to them anymore. So when we're talking about like safer supply, we also have to think of stimulant drugs. Montreal is we can still have access in terms of opioids. We can have prescribers and like get prescriptions who are open to this. But on for the stimulants level, you can correct me if I'm wrong, but I have no options for getting prescription-based stimulants. So the health system is not adapted to people do wind up in psychosis for toxic drug reasons. People will wind up in the hospital. They'll get taken there because they're not feeling good. They feel not good, and then they get treated. They go back, they go home, and they use their drugs again, and it just starts again. It's cyclical. There's also community sector workers and other people are who aren't well equipped to intervene in situations like this. They don't know what to do, they don't know where to look for support, and they wind up maybe having to ask for a P 32, a P 38, and that is not something we want to see in general. We shouldn't be asked that someone needs to be hospitalized forcibly. That's not something that we want. And everything that works and supports in mental health at this moment, there's up to 6-month waiting list just to see a social worker. And the person that you'll wind up maybe meeting, it's not you who choose that person. You don't get to fix. So maybe that person might not know reality of drug use, using stimulants, and what can be a toxic psychosis. Well, then support sadly will not be adapted to the needs of that person. I'm sorry, I'm just taking a moment trying to think, and I feel like I just maybe said everything really quickly. So, that's true. I wanted to mention a bit, Isabel spoke about it a bit. Um, when we're talking about different projects, often it's like in the community sector, we'll have a 6-month project. That's this duration. It's like as if we could fix a situation or an issue in 6 months. And then after 6 months, there's no more funding. So we can't move ahead with the project. And so you have to create a new project if you want continuing funding. And then it's not always obvious when they want to deal with the same theme. I had this experience a few years ago. And so you're always running after funding, and makes it that sometimes that it's difficult to be able to have a positive vision of anything that we can actually do. It can lead towards burnout and other issues. And that's kind of what I wanted to say about that. And the back when I was involved in La DIC, another Montreal organization, we were able to get involved different communications, trying to have ourselves listen to us. They invited us to come talk about what we were going through, what are the different issues related to drug use and consumption. And then I've noticed throughout the years, I don't feel that we were always actually heard or listened to. I am under the impression 12 years later that I don't know, in certain domains and people who are working on harm reduction, things have changed. And then, and eventually, at one point, I just asked myself, what am I doing? Do I continue on with this or not? And I stopped for a few years, and then I got back involved 3 years ago to get it back involved because I was like, now we have supervised injection sites. At least that's positive, and it helped me get back involved since 2017. So that's kind of it. I'm someone who's used a lot of stimulants, and then afterwards I discovered opioids. And so I know really the two types of drug use and consumption, and they're very different. I'm I'm not just talking about the effect that they have, but how we can be taken seriously. Um, in my experience, it was a lot easier to get support and a follow-up for my opioid dependency rather than in the time even being taken seriously for my addiction and dependence on stimulants. So it's been like since 2015 that I'm not using stimulants anymore. And back in the day, I was starting to use and consume opioids. So it's been a few years, and I really saw this clash of all the different services that could be offered to me for my need and addiction to opioids compared to what was available for when I wanted to stop my stimulant use. And it like, and it's so just there wasn't much to support that. So to be able to find a more support in financial support, but just more mental health resources, in my opinion, it's really necessary to be able to try to figure out so people who are using stimulants don't wind up in a psychosis, who don't wind up on the street or eventually in prison. because I have numerous examples that I can name that are just around my one of my someone was arrested 3 times and he was experiencing psychosis and he had to we had to like just push so far and let people know that he wasn't conscious of what was going on, and for that person it was for him, it was real what was happening. And you can't just how do you articulate that? People don't understand. I think I kind of went an overview around everything. Maybe if I'm forgetting something, just please let me know. Oh, thank you so much, Etienne. Now we're gonna take just a few minutes to fill out a little poll. And then after, you can we'll just move it back to Simone after. So as everyone is filling out the poll, or this is little survey. So something that I wanted to talk about, some of the different issues. I really want to congratulate safe injection sites, the drug testing that's happening in Montreal, in Quebec. There's a program that's in Quebec City that's getting developed. Hopefully will be in working order in this spring coming up, so to have new tools, to have a spectrometer, to help that out. And then what I was also speaking about, the desire to group together, create federations, and like, no, we're doing that. Let's create a cooperative or something. And that's something that I dream of a lot, to work more together in some kind of federation. So it may be this in an idea of Dove, DULF in Vancouver. Back in the day, I think they had different networks. And I know there's nothing that's perfect, and in a global situation, nothing is obvious. Even if we're able to create a network of distribution of different drugs, we will be limited by our ability to secure those and get receive those drugs and be able to get biggest. But we can it's well in that we have all the good drug testing. We can't have insurance on the quality. That's why going through the medical model and using pharmaceuticals, we know the drug or the substance was created in a lab, and we know exactly what's in it. Everything is um, um in there, the dosage, the molecule level, everything's guaranteed. I know in Montreal, it's a little bit more advanced than in Quebec City, but obviously dealing with different mentalities, it's not the same everywhere. In Montreal, we start having prescribed injectable opioids, and in Quebec City we're not even thinking of that yet. Actually, no, they're starting to think about it, but it's not tomorrow morning that you're going to have prescribed injectable opioids in Quebec City. However, if we're going to say we're going to prescribe Dilaudid, for example, and then sometimes it's hypocrisy, we're going to denounce this, or like only have a half analysis and not really think about it. Fine, we're going to give you Dilaudid, but we're not going to give you, sorry, what's the name of it? Like a generic Dilaudid, because we know the Dilaudid will totally dissolve, versus the no name brand will leave a wash. So we'll give you the one, um um we know the person wants to inject it, but we're not going to give you the one that you can inject. We're going to manipulate and use a different, so we're not going to let you be able to dilute it so you can inject it. And so you're like, what, why would you prescribe this? And it's like these they're not, the analysis is not going, it's not further. Maybe people are worried, they're worried about shock, like upsetting people. And I need to keep on speaking with my colleagues and my friends who work more on the medical side to be like, what is the motivation before not going like the full step? Like you just half prescribe, and whether or what are their worries, and to not actually support people. And so that these worries can't just like reign over rational decision making, because it doesn't make sense. So that's something I wanted to follow up and name. And I wanted to say thank you so much, Etienne. I just know the organization Addict, it's definitely a place that people can be heard, and get together, and definitely a good harm reduction space. So ADIC is such a good spot to go. However, it's not actually accessible all in different regions. I know it works elsewhere, but I know LADIC is a really good place for people to get together and try to like empower and make decisions together. So that's kind of what I wanted to say. Thank you so much. I think now we'll go to the different question and answer period. So I want to invite everyone to ask their questions to our panelists. Frankie B, would you allow me? I would like to add a little thing that I prepared. I was just wondering if I can say a little something. Yeah, Anais, we're listening to you. So when we're talking about some new initiatives like Cactus, we talk about the safer injection sites, and we opened a new thing called, we call it the checkpoint, and it's a place that now there's a new project, so the checkpoint project that we're working on. So I just wanted to name that, and I just wanted to let you know that I was to look, speak with the public that's here and all the invited people who are here with us. If you ever have more questions, I'm sure Stimulus, I will give you my email or a way to be in touch and to get in touch with us. And if it's not me, to be in touch with one of my colleagues. Um, we want to really be able to work with you depending regarding all your needs or anything. So thank you so much again. I really enjoy being part of this presentation. Thank you so much, Anais. So I will make sure you can put your information in the chat. Well, people will help do that. So anyone who's interested, we can add that to the chat. Just to add a little life to this whole situation. Something that we named and brought up in terms of drug testing. One thing it's important to realize that Quebec is a huge province, and that we have basically resources are concentrated in the big urban centers, which are basically Montreal and Quebec. And there's some small initiatives here and there in different regions, but people who are dying from overdoses still die alone in the suburbs in a house. And and what's one of the biggest barriers to access support is stigmatization. And there again, it's the decision makers, the politicians, these people don't put enough accent or importance on education on everyone to get rid of these prejudices and stigmatization, because everything that we spoke of today goes back to this. It's a stigmatization of people who use drugs and consume drugs. It's a stigmatization of issues around mental health. It's a stigmatization in terms of people who are already marginalized. It's a stigmatization for the health services and health support for drug users, and the stigmatization of people in the general population, of what could be a site that would wind up in their neighborhood that could provide different services that would help population X. But with all the phenomenon that we're thinking, like, people don't want this in my backyard, that comes with having that in neighborhoods, and the stimuli as was stigmatization when we're talking about toxic drug supply, because if people didn't feel stigmatized like my daughter, she wouldn't have isolated herself to use drugs, and she might have not died. She could have gone out and spoken to someone, and she could have spoken to someone to receive support or be with her, and she could have gone and reached out to different services that were available, or for her in the little network for where she was, where she died. There were 3 organizations close to her, and why she didn't go there is she didn't want to feel judged, and she didn't want other people to know. So her drug use, she hit it. There's just her and her partner. They were both using stimulants in a recreational manner, but they were also using Dilaudid, and that's eventually what got to her. And that's she didn't tell anyone that she started using that, and it was a total shock for everyone, because she totally isolated that use. And so the stigmatization, if that was one big battle that we want to take on, I think that's what it would be, to get rid of the stigmatization so people can speak openly about issues with their drug use, consuming drugs, drug toxicity, what's needed, the access, support, what can exist outside of major urban areas. I think that's the main thing that like really brings us all together. And we're talking about stigmatization. And Anais brought it up. As soon as you have other intersectional issues that are like adding on, if you're a trans person, you have HIV, you're someone living or houseless or living in the streets, you're a person, racialized person, you're a migrant person, and you have more and more stigmas on top of that. It feels like David against Goliath in that fight. Me and my struggle, working trying to fight this stigmatization, is trying to bring a human face to drug use, a more personal face, like let's make it person. And that like that's the part of my mission. I just wanted to do name that, because I feel the stigma, that whole stigmatization, is basically putting a wrench in the wheels to stopping us from move forward. So thank you. We have some questions in the chat. Someone wants to understand, someone lost their son because of fentanyl and methamphetamines, and the person saying this safer supplies for of sorry, safer supplies for these drugs, because there's not enough prescribers. So in our communities, there's a waiting list for over 500 people, because there's not people to just surprise the dexedrine and stuff. And so people who are using meth and cocaine, they're turned away from receiving a safer supply. So what are you feeling about the way that college and physicians, surgeons monitor and control the opioids and the lack of stimulant protocols? So what do you feel about that? So once again, it comes back to a lack of education. And we're talking about the doctors' schools, like who the doctor colleges that train these doctors. New doctors can go get out of their whole program and not have received any training or contact with people who are dependent on substances. So then the problem's there that these prescribers, pharmacists, doctors come out of school and they do not have a proper knowledge of this issue, and that has to change. It even has to change at the university level, who are recreating medicine and medical programs. And then hopefully, then if you integrate this as part of someone education, they'll start to be able to change the perception of people who have substance dependencies and how doctors will treat these people and try to maybe help them and push them depending on what drug they're using. So not just focus on opioids, but also be able to deal with stimulants, like how it was mentioned before, like the lack of. So just to move along in the same direction, I think one of the major um how people are prescribing and doing a prescription of safer supplies, just prescribing stimulants. We're talking about Adderall and Vyvanse and stuff for this like typical ADHD drugs. But I was looking at the dosage that they were offering. I don't think it would have satisfied someone who is an actual user of stimulants. When you look at the dose, the maximum quantities for per day for a safe supply in terms of Adderall or something, I was looking, and just to be functional, not even to be like a little buzzed or high, they needed a double dose of the maximum that could be prescribed. So that was just like not working. And then the other idea I kind of it went by. Sorry, thank you. Don't worry about it. I'll stop muting myself in between each person. So there's someone else who is saying, Simone's talking about concerns about the different prescribers. What are these concerns? So yeah, this brings me back to the thing that I was asking that I forgot, right? So what are the main concerns? They're scared of killing their patients, right? Because if there's an accident and a patient passes away because of the prescription, that's our main worry. And so, and then in another webinar that we did, we were trying to name, I'm forgetting the name of the person. It's oh yeah, Accupsud Jérôme. He brought this up. He's been an activist for a very long time, and how we can assure and reassure these prescribers. And it's like, right, when they come out of these students become doctors, and if they were never having this as part of their training and they never learned about these situations, and the person shows up and they're like, hey, I use this a substance and this amount, and then them in their books, and that amount should kill the patient. So they have no reference for what's actually needed. And I remember last week we lost a member, one of our activists who passed away last year. She was in care, and luckily the medical team believed the partner, said, don't worry, you can give her this dosage of fentanyl. It won't kill her. It will just create her less anxious and make her more comfortable. And that palliative care and those workers trusted the partner and used it. But that was exceptional, right? And when I was at the summit of drug use or addiction, and we were talking about the question of this ethical reflection of these ethical stuff. So why can't we prescribe people's choice substance, and how can't we defend this on an ethical level? If we're talking about, if the doctors don't want to be pushers, don't want to be drug dealers, right? And I was trying to explain it in terms, we're talking about, like, say, abortion. So all these reflections, and like, why did or with the medical supported death, or the right to choose when you're going to pass away, and how did that all work? So doctors didn't want to kill a person, right? It's of abortion or medically assisted suicide. And they did the pros and cons, and they looked at the risk and what the risks of not doing it versus the risks of doing it, and eventually they said, no, we're going to do it. It's the same thing. And so that's what I'm trying to do in my entourage, and talk about it, even if I understand the worries of prescribers, just so that they can be assured and convinced that even if there's pressure, that you think they're going to do more harm than good. No, in the reality and in the long term, you're doing more good than bad. And it's really to look at that. So that equation. Thank you. Thank you. Is there a prescription of fentanyl in Montreal? I'm living in Squamish-Mississauga, and also known as Vancouver, and we are starting to prescribe. It's very difficult to get a safer supply, so we're running after nurse and daughters who want to prescribe. You have this problem in Quebec. So to get the prescription for fentanyl. So I see Isabel and Etienne who are saying, yes, we all have this same problem finding people to prescribe. And I'm still having difficulty getting people who can prescribe injectable heroin. We're still there. Are there support for parents, families, or sorry, I missed the end of that question, so I will try to catch up with this. I don't know if Michelle, whose Mom Stop the Harm organization, there are groups all over Canada who are pushing, who are exist. In Quebec, it's a little harder, however, because we have a program that's facilitated for and by, so the peer-to-peer support. So we need to recruit parents who want to do peer support groups. It's harder. We have one mother who does it, but however, we're looking for another person to facilitate a group for parents or people who are close and have loved ones who are using drugs. So we're trying to find people who are the for and by who want to work on those groups. There's different services that exist. And I think one of the best things that we could do is to really help sharpen people's skills a little better. In my experience, all the people who connect with me, and then they'll basically, it's because they've like, I don't know where else to go. And I really feel that it's so important to have the for and by support, the peer-to-peer support, because someone like me who's lost someone close, I want someone else who has that same experience, who knows what it is to have a loved one who's using drugs, and they'll understand better. So I think it's so important. There's all different kinds of support that exist, and that but people who don't have that lived experience. So us who are motivated in like this Mom Stop the Harm, they were really for and by people who have these lived experience, what it is like to go through this. That's why they're really hard to organize these groups. There's numerous virtual ones in Canada. And so maybe we can push you and show you where you can go to our website, and it's called Healing Hearts or Holding Hope are the two different support groups. Holding Hopes are for families and close people, and then the first one was for mothers. So there's two different groups. We do not mix the two groups together because the two lived realities are very different. But we are developing more and more because it's one of our projects that's on the go. We got a federal subsidy, and we're able to create them slowly through that in Quebec because we're working through our national or federal organization. However, it is difficult, and it's something that we have to develop more in a national strategy to fight overdose. It's so important to have the support in the network and for loved ones. So how do we do this financial support? How do we put it together? And how is that all going to work? So I'm still unsure how our organization, because we can't apply for these subsidies because we're we're Quebecer, not national, so it's all difficult. It takes time and energy to apply for these, and when there are very few people who are working, it's hard.
Thank you, Isabel. We have an anonymous question. It says, could you comment on the need to be diagnosed with a disorder related to a substance use in order to receive medical safer supply? What would be your recommendations for someone who we might describe more as a recreational user? I would be interested in answering this. This touches on some of the elements that I tend to reflect on when I say that I'm constantly evolving in how I view things. I don't always have the answers. I'm not certain about much. This is one of the elements that gives me pause to think about the difference between someone who really has a trouble related to substance use and someone else who has a recreational use. This is the whole idea too of putting together a cooperative. I think it would make more sense in this context and might reassure prescribing doctors as well. So in these instances, I think that prescribing doctors might experience their role more as pushers to offer prescription for individuals who really just want a access to a reasonable quality, good quality drug. And that's where I fall more on the legalization side of things. For someone who is a recreational user isn't necessarily going to have the same psychosocial disorders or challenges related to um, their drug use, and it becomes a question of public health. An individual who benefits from a prescribed substance because they use it on a daily basis. It can have an impact on their finances, their activities. They have to acquire the funds needed to pay for a substance, which can become expensive, especially if we're using a large quantity on a daily basis. So I see advantages of having a socialized program to help someone. You could think of someone who uses heroin. If it's prescribed, they could go to work. They can be a good, active, responsible parent, all of that with the same individual if they're required. And I would often give the example of a colleague who was scandalized. She found out that a couple had spent an entire day on Saturday with their kid in the back seat because they were trying to find their dose and they couldn't succeed in finding it. Well, she's trying to say that you should call youth protection, but if that person had just received the prescription for the substance, the kid would have spent the whole day playing instead of going around town. So I think it's very interesting to think about these two different types of use, and it's something that's very much in evolution for myself. I'd be curious to hear what other people might think about that. And I think that it's a really relevant question. I don't know if anybody else wants to offer some answer to it, or should we go on to a different one? I agree completely, Simon, and it touches on a little bit what I said earlier, even for myself from my own perspective. Uh, Obviously, prescriptions will solve a lot of problems, but I think we really only see the first layer. We don't yet see all the ramifications that it could have positively on individuals who get a prescription in terms of being able to stabilize their life. I honestly believe that my daughter probably wouldn't have moved towards abstinence for quite some time. And for her, prescription or at least access to a safe supply that was regulated. It doesn't necessarily have to be medicalized, but at least properly regulated. It would have allowed her to, well, be alive today and to stabilize her situation. And by removing the stigma, I think it would have had a positive impact on her life. And that's what I believe. And I think it's a good example. We have Kira who's asking, could you comment on the situation in Quebec related to the services offered to youth? A number of harm reduction services are more focused on adults, but it would seem that harm reduction in youth, especially teens, remains particularly stigmatized. I would respond to Kira to say that we have a lot of difficulty getting into schools to do prevention activities, even just to teach them how to use NACs alone. So you have to think the degree to which, yes, we would like to have more specific services for youth, especially youth that are marginalized because they're considered to be higher risk. But for everyone else, we have a hard time with school principals. We had a parent in Outaouais who wanted to go and speak in schools. The principals just never answered his requests. I consider myself lucky that I had one school in Trois-Rivières that has approached me to come and speak to their graduating class. But my discourse is really going to be to say, that we know that you're going to be taking drugs, you're going to see people taking drugs. So what can we do to reduce your risks? Right? It is about reducing risks among our youth, how to intervene, how to recognize an overdose, what to do. Don't panic. You have to call um, emergency services. But I think it's unfortunate that even today, within the education and prevention programs that we have, it's still so demonized, even though, our youth are using drugs. We shouldn't bury our head in the sand, and we should be responsible as adults to give them the tools that they need to behave safely. We are doing our jobs as educators and parents if we give them all the tools that they need, all the knowledge that they need. And often people will tell you that your drugs aren't your parents' drugs anymore. The situation in the world of drugs has changed so much. It isn't what it was anymore. And so I do think we need to raise awareness around this, that the illicit drugs that are available are highly toxic because they're not controlled from one dose to another. You don't know what you're taking. Yes, you can test it, but maybe the part that you get tested is fine and the next isn't. It's like a cookie, you break it in two. One person has all the chocolate chips and the other one gets none. So unfortunately, I think we're still quite far behind when it comes to education and prevention, but it's going to have to change quickly. Our youth, we've seen it. We have a number of parents who have lost children, often in cases where they were left in a room because people thought that they were just sleeping, or they didn't call for emergency services quickly enough. We have these situations that are going to become more and more common, and we're going to have to do something. Isabel, thank you. Naja? I was just going to say that, and I feel affected, involved in this question. I've worked in youth organizations, but I'll allow Anais to answer first and then speak afterwards. Oh, thank you, Naja. When I began to get involved in this field, I did this as a volunteer with a project that was working with youth. And this the program still exists. The name has changed now. Two projects for 14 to 25-year-olds. We were able to refer to the Two Hands Clinic in Sherbrooke. It's clear that drug use has always been present. And so it was important to start to know more about what was going on. We had Project 10 to meet to respond to needs. Project Backs was more my field, and it's been merged with Project 10. It's named after someone we had lost at the time who had been named Max, and it was focused on stigmatization. And so we wanted to talk about suicide rates and drug use in our communities and to talk with youth about it. So this is something that we had targeted. The Two Hands Clinic is still there, still working with youth. Project 10, as I said, merged with Project Max, and they're still in operation, offering resources to youth between the ages of 14 and 25. And otherwise, for those who are wondering, for us as trans people and members of the LGBTQ community, we have an organization that supports people through all types of different issues in society. Thank you. Thank you, Anais. Naja, please. Yes, thank you, Anais. I think you said almost everything that I wanted to say as well. I don't wanted to add that I applaud the work done by a lot of youth organizations in Montreal and around the province, especially LGBT plus organizations and organizations that offer support to young people who exchange sexual services for money. These organizations that support a lot of marginalized populations focused on harm reduction. But these organizations also face the challenge of reaching not only those who they want to offer resources to, but even just more generally into schools. I think this is a very significant barrier. This is good for the youth who use these services, but it becomes very difficult. You can imagine for youth who are isolated, who haven't found their community yet, who haven't learned about the existence of these resources yet. And I think that it should be a priority to have these services and this information, this education be accessible for the general population and for youth in a non-stigmatizing way. Because obviously we see the consequences of campaigns that are based in fear, and the consequences is that it either does nothing or it simply worsens situations. So I did just want to take a moment to speak about that. Thank you, Nasha. I know that we spoke about it briefly when we talk about reducing risks rather than reducing harm, that the word risk is less stigmatizing than harm. I do think that it's part of so the vocabulary we need to change in our overall discourse. We know that government and certain organizations have focused on changing the vocabulary to try and lessen stigmatization, but risk reduction is a term that's much more common in Europe, and we've translated it into French here as méfait for harm. But I think that the word risk is less stigmatizing, and so maybe I'll try and use that more often myself. So Michelle Miller, who asked, what do you think about youth-led discussions or discussions led by peers in schools? I know that the Fondation Jean Lapointe has a prevention education program where youth are trained in each school to be to do peer interventions. I think it's a very positive influence. Are they users? Not necessarily. If we said support peer drug users, I think there'd be a lot of intervention workers who would be a little freaked out, but that's really what it would take. But I think it's something that we would have to see in CEGEPs and universities as well. I feel like things are starting to move in that direction. But these primarily are decisions that have to be made by the institutions themselves. There's a lot of work left to be done. You could think of the case of University of McGill, who about a year ago adopted zero tolerance in its residences. And so people who are residents at the university can't use anything, the risk of being kicked out. But we know that people in that area they continued to try and take actions to save people's lives. But you can see how in 2020, 2021, 2022, a university who is internationally recognized puts a zero tolerance policy and position in its student residences. I think that's pretty shocking, to be honest. It just leads to more harm and much higher risks for the people living there. Thank you. We'll go with the last question. Hello, thank you for the presentations. I had a question for NAS. What is the priority or priorities for Aztec for the time to come in terms of harm reduction for trans individuals? In terms of harm reduction, we have someone who is supporting me on our street work, one of my colleagues, Lauren, who has been working on that since this year to better target the populations in need. Otherwise, harm reduction. Well, we always try. And for myself, with the contacts that I've had from my time, I try to always keep contact with the sex workers that I still have a relationship with, of offering support, and with new sex workers as well. That's a bit word of mouth. To talk with them about to offer them safe materials, access to hormones. Not too sure if that answers the question fully. And yes, I'll pass the floor now to Nasha. Before going on to the conclusion, I wanted to share the results of the questionnaire. We have people primarily from Quebec, Ontario, the Northwest Territories, and British Columbia who joined us today. Majority of participants are women. We still have about 45% English and 55% francophone. So about still close to half-half. We also have, I can see here, 20% of people present are racialized in the public with us. And most of the people who've joined us are from the community sector, which is often the case with our webinars. But we still have a significant number who have used drugs. I just wanted to share the results of the survey. I want to thank everyone for your participation. We had 100% of participation rate. So that's very lovely. with that, I think that if it's all right, Frankie, you could do the first part of the conclusion today, and then I'll finish up. I think I will let you do it. Yes, of course. Rest your voice. No worries. First of all, I would like to invite everyone who is in the background to join us here. So if you're comfortable turning on your camera, I would invite everyone who helped with interpretation, the tech background, the social media to join us. I just want to offer my thanks to everyone. First of all, to our panelists, to Anaïs, Etienne, Isabelle, Simon, to our moderator, Frankie B. A big thank you to Coop Largo, who has helped us with our last webinars and our next ones, we hope. Thank you, Danielle and Jean. And I also want to thank my colleagues, Shay, for her wonderful support and her work in general, for having created the Stimulus Connect platform, Jen for having taken care of the chat, Iman for having translated all of the questions, and I want to thank Ryan and Alicia who took care of everything related to social media, did the live tweeting, and who have been taking care of everything on the communication side. Other than that, the end of this event, you're going to receive a evaluation survey by email. It takes about 3 minutes to answer. So I just want to thank you in advance for your feedback. And as important as it is to recognize the lands in which we find ourselves, we also want to dedicate our work to those who we have lost due to toxic drug supplies because of governmental policies and the war on drugs. And I just want to rededicate this work to all of those who we've loved and lost. I think we could all just take a moment together to close our eyes and take a moment of silence. So, yeah. Thank you, everyone. I really appreciate it. I would invite the panelists to stay on the call. I'm going to have a little debrief afterwards. And I just want to thank everyone once again for your participation. When you're ready, you can leave the webinar. Thank you so much for your participation and your questions.